Good evening. I'm Elyse Lower from the University of Cincinnati, where I'm a medical oncologist, and we are very happy to have our esteemed panel tonight. It's going to talk about what's practice changing on Monday morning after our recent virtual San Antonio Breast Cancer Symposium. I know so many of us missed not just the in-live presentations, but the Riverwalk, the food, the entertainment, and more than anything, the camaraderie. You know, we can listen to the talks, but I know personally it's just flat out not the same. Being able to talk to somebody in the hall or run into them walking on the Riverwalk is really part of the meeting. So I'm really happy that we're going to have this session looking at the impact of San Antonio presentation on triple negative breast cancer. It's kind of that hallway discussion. So I thank our participants and obviously all of you who are listening in tonight. I'd also like to thank our sponsors, Pfizer, Natura, and Gilead, formerly Immunomedics, now Gilead, for helping us to present this presentation tonight, and certainly Total Health Conferencing. Before we get started, I'd like for each of our panelists to introduce themselves on our little Brady Bunch screen here. And Tiffany, let's start with you.
Sure, thank you so much. I'm Tiffany Traina. I'm a breast medical oncologist at Memorial Sloan Kettering in New York and the section head leader of the triple negative breast cancer clinical research program there. Thanks, happy to be here.
Thanks, Tiffany.
I think, am I next?
Yes.
I'm the next Brady Bunch. I'm Maimah Karmo. I'm a 14-year survivor of triple negative breast cancer, and I work to end disparities for people of color living with TNBC and facing disparities across the country and the world, and ending barriers for those who are underserved.
Erica?
That's very hard to follow. I'm Erica Terry, CEO of Susan G. Komen in Kansas and Western Missouri. And being inspired by Maimah and her work, we have been solely focused on health equity in our region because we know that we can't possibly achieve our mission to end breast cancer forever without first addressing health equity. So I'm very thankful to be here tonight.
We thank both of you very much. And last but certainly not least, Dr. Mamounas needs no introduction, but Terry.
You're on mute.
Audio, you're mute.
Oh, victim. So yeah, Terry Mamounas, breast surgical oncologist, work at Orlando Health, UFL Cancer Center in Orlando. And I also chair the breast committee for energy oncology.
Well, thank you. This is going to be a bit of a mix of, you know, what's new in the science, but we also want to make sure that we keep in mind how important it is to think about ways to improve clinical trial accruement, particularly in our underserved communities and in the triple negative sphere. I think we all know what a problem triple negative breast cancer has been. And, you know, 15% of those 270,000 cases annually diagnosed in our country will be triple negative. And we know that unfortunately, women of color tend to have a higher chance of being triple negative than others may. So I want to start by talking a little bit about some of the targets, because, you know, my patients always thought it was terrible to get that diagnosis of triple negative because there was no target. There was no hormone receptor, there was no HER2. And we sort of said, uh-oh, you're triple negative. We just give you the usual chemo. But now I think it's obvious that we're starting to see targets in this scheme, and it's helping us to slice and dice this triple negative a bit more. And I think one of the ways to think about this is the role of immunotherapy and how it's changed our thoughts, both in the metastatic as well as the neoadjuvant setting. And Keynote 355, I think, was a very important paper and gave us a little bit new insight about chemo backbone that may need to go with Pembro. Tiffany, you think that this is practice changing, or you want to give us your thoughts on how best to interpret this data?
Sure, happy to. I mean, I think that it's triple negative breast cancer that actually welcomed in the first immunotherapy with data in breast cancer altogether to offer to our patients. And that dates back to nab-paclitaxel with atezolizumab more than a year ago now. So that has really been practice changing. And so reflexively, when I'm meeting a woman with a diagnosis of advanced triple negative breast cancer, I need to know what is the PDL1 status of that tumor so that I can really refine and make the best recommendations possible. So the Keynote 355 data that was presented at ESMO looked at different chemotherapy backbones than what we had available prior, which was just nab-paclitaxel. Keynote 355 looked at plain old paclitaxel, nab-paclitaxel, or the combination of gem-carbo with or without pembrolizumab. And so what we saw back at ESMO was that the addition of pembro to any of those chemotherapy drugs improved progression-free survival, particularly in the patients that had PDL1 positive tumors. Now, Keynote used a different testing strategy and definition for PDL1 positivity. And this is something that I think we're all still trying to figure out. I'd be curious to hear what others think. We've been doing PDL1 testing using SP142, the Ventana assay from the atezolizumab Impassion study. Here in Keynote, the definition of PDL1 positivity is by a CPS score. So what we saw was CPS score greater than or equal to 10 in PDL1 positive tumors derived the greatest benefit of adding pembro to backbone chemotherapy. What we were all wondering is, were there differences between the chemotherapy drugs? And I think what we could come away with from the data at San Antonio is that pembro seemed to add to all of these chemotherapy options. The trial was not powered to look at particular differences between chemotherapy. So I wouldn't overread into any small differences that might appear to be there between taxanes or gem-carbo as a backbone. I think my takeaway was that pembro adds to all of these chemotherapy agents.
Yeah, I think that's an important contribution. You bring up something that is so, I guess, gut-wrenching to all of us, which is doing the assays and figuring out who is PDL1 positive, which tumor is most likely. So how do you handle that in your institution? Do you do PDL1 in your institution? Do you send it out? Now that we have 2 assays, 2 different studies showing improvement, do we have to do 2 assays? Can we do Foundation 1 or Caris, or what's your thought on how are we going to identify this group?
So at my institution, we've been using SP142 to define PDL1 positivity from the Impassion data, really in the first checkpoint inhibitor to market for us. I thought we saw nice data that Hope Rugo presented a while ago now, looking at using other PDL1 assays in the residual tumor tissue from the Impassion study. And it seemed like using 22C3, you were still capturing about 40% of the population as a high CPS score. And if you remember from Impassion, about 40% of the population were positive by SP142. I think what we're not certain about is just how much tight concordance is there between those 2 antibodies. I think our practice is to begin with the SP142 antibody for testing, but I imagine we're going to see lots of other institutions and labs having 22C3 as their available assay. And unfortunately, I don't know if we can conclude whether one is more optimal than the other, or if it'll be required to do one assay over another just to get access to the drug.
Yeah, I think insurance companies are going to will be somewhat driving this, unfortunately. Yeah. How do you handle it in Orlando? Do you know, Terry, what your institution's policy is?
I think similarly, I think we'll use the one for tezo treatment, but now obviously, with the pembro data, that may change. We haven't gotten a chance to sort of talk about it. Well, what's interesting also in the pembro data, that even with the CPS score more than 1, you did get benefit. Similar, but a little bit less. So at least, obviously it's optimal to use over 10 or over, but I think you may get benefit still with any PDL1 expression of 1% or more.
So let me take just a step back. And so you have a newly diagnosed advanced triple negative patient in your clinic, and you've rebiopsied, you've ascertained she's triple negative. What is your next step? What other testing do you do on her tumor at this point? What do you think is practical for our group? You do PDL1 on everything? Do you do BRCA germline mutations? What do you do at this point? Yeah.
Yeah, it's a great point, because I think we can't just stop at a definition of TNBC or a diagnosis of TNBC. We really need to start to describe additional biomarkers that will help choose therapy. So often, if I'm setting up imaging to get a biopsy for somebody who I suspect has metastatic disease, I will often begin to do my PDL1 testing on archival primary tumor. It's simple IHC. You can get that result rather quickly. So even while we're waiting for confirmation, we're already starting to think about what our first steps might be in chemotherapy backbone and checkpoint inhibitor. It's also critically important to have germline testing for anyone with a diagnosis of triple negative breast cancer, whether this is early stage or advanced. So hopefully by the time someone has a diagnosis, we already know that. And then we are very much doing next gen sequencing, because hopefully we'll identify other potential biomarkers that could help stratify for clinical trials of interest.
Yeah, absolutely. Yeah. So Erica and Mamou, I think this is kind of where we need a little bit of your help, because so many of our triple negative patients are a little bit fearful about going forward with genetic testing. And as we talked just a couple of minutes before we started, it is something that I think most groups routinely offer. And how can we convince women of how important this is? Because not knowing this may deprive them of some very important information.
I think that's a great question. Yeah, I mean, to be honest, oftentimes my patients say they're not even offered genetic testing or trials. And so, being offered is a key thing that has to happen first of all. We also know that people who are Black and brown have faced a lot of barriers, and among them, the trust barriers that have come from years of systemic racism and health inequity. So like even discussing these trials to a patient who's a new patient, she's totally lost. How do we make this content more palatable to a patient who's scared, who's newly diagnosed, and make it more understandable to the patient? We have to work together to make it more understandable. We have to collaborate with patients more at the beginning of the trial, at the poster process, the beginning of the whole process. We have to build trust. That means hearing the patient and seeing where they are, meeting them where they are, asking why are you afraid, what barriers are you facing, and how can we build a relationship that can help to lead to better conversation and better access to treatments, to trials and treatments, and better outcomes.
I have a question, even though I'm not the moderator. How do we even approach the notion of even having the initial conversation to get a patient in, from your perspective and the incredible work you've done at Tigerlily? Because I often sit in a lot of these discussions and listen to webinars, and the immediate answer is, oh, we got to do more education if people just knew. And that can be part of the solution, but it doesn't strike me as the actual solution for this challenge and this issue. So I'm just interested in knowing, because at the end of the day, we want to improve health outcomes and save lives. And so where do we start with encouraging women, especially Black women, when we know that they are dying at a much higher rate from triple negative disease?
One of the things that struck me most, we took women to San Antonio Breast last year, and women of color from across the country. And one of the women came up to me, actually 2 of them, and they were in tears. Never seen another Black patient that was metastatic before, nor a Black breast cancer patient leader. And so, if the health system is surrounded by mistrust and the legacy of things that have happened in the past, and are still happening now, frankly, I think having people that look like them, like us, leaders and patients, is really important. To say that I know where you are, I know where you come from, I know where you've been, I get it, you're afraid. But unless you try and understand where we're going, we're not going to get there. And so I think that open-hearted conversation, that's what my patients and I have. First of all, I look like them. I look like us. And, to be where I am today is really like an honor. I've had to fight to be here. I came as a refugee when I was 15 years old. And when I found my breast lump, I got dismissed for over 6 months. I had to push for diagnostics. And when I got them, I was single parenting, had to drive an hour to treatment, had to leave work. And there are all these barriers that we talk about that are real people barriers. And so it's having somebody who looks like you, who talks like you, who gets where you've been, and who isn't a hired gun, who has walked the journey. I think that's where we start with that conversation. So I think that the science is really amazing. It's all this work is great, but unless you pair science with soul, you're going to be at a loss. And I think that's how we start to have that conversation and get someplace that's going to be changing and transformational.
And again, sorry, I'm interjecting.
Yeah, at least you're fired. Just kidding.
And can we use this year where people have learned so much and have seen with their own eyes and have seen the impact of COVID, the global pandemic, to various populations, and translate that passion right now into reforming essentially clinical research for the intended outcome of improving health outcomes and saving lives? How do we do that? Systems change.
So here's where I get like my head scratching, because if we can figure out how to find a COVID vaccine in 6 months, and we have the money to do that, and the industry partners, and how do we not put that laser focus on disparities? I think that's what bothers me, and I'll just be totally honest. So when the entire world got COVID, it was a disease that didn't have, color. It didn't care if you were white or black or brown or blue. Anybody could get COVID. And the entire world was focused on how do we figure out to get a vaccine to end this pandemic. 6 months or 7 months, we got to that solution, right? Mm-hmm. How do we get there with health barriers? And just if we all come together, collaborate, put our heads down and have one goal, a designated date, time to get towards ending barriers. The barriers are simple. I mean, they're there. They're financial, they're geographic, they're trust, they're trauma, they're social economic. If we all come together and target the barriers and put a time-bound, specific, measurable thing in place, we can get there. So I think it's possible. It's just not about who got there first. It's let's do it together and let's just get it done.
Sorry to take us down a philosophical discussion.
I think it's important. It's about the science and people. We can't discuss science and not people and how it impacts them on a social level. So you shouldn't apologize. I don't.
No, absolutely. I do think that the difference between COVID versus tackling, getting the COVID vaccine is it was one thing, it was one goal. Yeah. And so I think sometimes what happens is we get too diffuse. So I think we need to, if we're going to tackle this, you tackle it step by step. And, you have to have measurable outcomes, and you have to look at it perhaps a little bit more granular, because nothing's going to change overnight. Work on clinical trials in which you have better representation of what the needs. We need to have more help in our clinics too. I mean, really and truly, I think this is navigation. This is making sure that patients complete chemotherapy, that they go to surgery, that they don't get discouraged and then not show up to see Dr. Mamounas to get their surgery. I mean, we have to work all the way through this process, and we need to partner. I think that's clear. Yeah.
Also, I mean, I think
it goes back to the barriers, though. The barriers are, leaving your job to go to treatment, leaving your kids to get without daycare money to go for follow-ups, not having money for a co-payment. So it's not just that people of color don't want to adhere. They're just barriers that exist that won't go away. So if you invest in ending barriers, you have more adherence, more follow-up, and better outcomes. And so I go back to the barriers every time, because I know if we invest in them and they go away, we will have better outcomes within follow-ups, treatments, trials, and, overall lifespan.
Dr. Mamounas?
I think that our response to COVID may actually help reduce some of those barriers, because we've seen restrictions around clinical trials loosen up, right? Oral investigational agents were able to be sent to patients' homes. Telemedicine allowed somebody to not necessarily leave their job, but just step out for an hour, do their visit, do what they needed to do remotely, and then return to work. And so I think that hopefully we keep some of these positive innovations after this pandemic is a thing of the past.
Terry?
Yeah, well, I was going to say, not to take away from this important topic, but also I would sort of remind us Mary Claire King's talk at San Antonio, who reiterated the need for sort of universal genetic testing for every woman at the age of 30. If we can prevent many triple negative breast cancers, and I think her take-home message was nobody with a BRCA mutation should be diagnosed after a breast cancer. So I think that is probably one of the most important things we can do. Identify the women at risk, potentially prophylactic mastectomies. I mean, there could be multiple ways of dealing with this, but knowing that you have this risk. So I think that will go a long way in terms of education, and also genetic testing is much cheaper now, can be performed fairly easily, quickly. So I think that I'll make that point too, that we can prevent a lot of suffering by doing that.
The question then comes in with who's going to pay for that.
I
And
think the healthcare system should
Right.
Well, now the genetics, you can get a full panel for $250.
it's cheaper.
Not that prohibitive. Those days are over when it's 4,000 and 5,000. Compared, that's cheaper than a CAT scan. That's cheaper than a pelvic ultrasound. So again, you know, the cost is really dramatically changed. That is not the barrier that it used to be. I mean, you know, everything's a bit of a barrier, but I think we've nibbled away at that because we have so many companies that now provide the service. It's much easier and much more efficient to get the testing done. Yeah, clearly there's a lot of ways that we need to attack each of the problems. I'm going to turn back a little bit to the science side, and then we'll try to segue after each group. So I have this kind of in 3 pods, but the next thing I wanted to talk about is a potential other target. But as we probably know, the pandemic brought us good things. It brought us so many new drugs for advanced breast cancer, really kind of an exciting plethora in the HER2 news sphere, but also in the triple negative. And sacituzumab govitecan was also approved during the pandemic time. And that is the first specific antibody direct conjugate approved for triple negative breast cancer. So for the first time, we have a drug approved specifically for our patients with triple negative. And ESMO suggested that clearly when people received Trodelvy or sacituzumab compared to dealer's choice chemo, there was an improvement in median progression-free survival. It was a doubling. Overall survival went from 6 to 7 months, and response rate went from 5 to 35%. So very impressive data. And then San Antonio looked at that TROP2. So the target of this antibody drug conjugate is TROP2. And so they actually looked at high, medium, and low TROP2 expression and were able to show a response correlation. The higher the TROP2 expression, the greater the response rate. I don't know if that means we're all going to start wanting to do an assay for TROP2 or not. I'm not quite sure it's there, but somewhat of an interesting theory that maybe this will be potentially a biomarker that we will look at in our triple negative patients. Tiffany, your thoughts? Do you think this is practice changing or?
Yeah, well, I certainly think the approval of sacituzumab is practice changing for our patients with triple negative breast cancer. I mean, in the 3rd line setting and later, what we saw from the ASCENT study was overall survival doubling from 6 months to 12 months, from progression-free survival increasing from under 2 months to almost 6 months. So it's highly active. My takeaway from the data at San Antonio was that regardless of your TROP2 expression, getting sacituzumab was better than treatment of physician's choice chemo. So almost 90% of those triple negative tumors expressed some degree of TROP2. And even if you were low TROP2 expressing, it was better to get sacituzumab than plain chemotherapy. So I think this really is practice changing data. The other thing that they looked at as a subset exploratory analysis was whether there was a difference in performance of the drug in patients with germline BRCA mutations. So the antibody drug conjugate uses a payload of SN38, which is a topo-1 agent. And so that can cause single-strand DNA damage. And you would think if you have an underlying issue with homologous recombination, that maybe you would see folks who had a germline BRCA mutation have a better response to sacituzumab. And granted, the numbers were tiny, but that didn't appear to be the case. It really looked like sacituzumab benefited all.
So I think we keep trying to better refine what constitutes triple negative. We know it's not just one homogeneous group that we might think about more with a HER2 driven or the hormone receptor positive. So these are ways I think to help with that quite a bit. Yeah. So when you're working up your triple negative patient, you said, and I think it's really important, you try to get PDL1 early, maybe archival tissue, or perhaps on the core biopsy that's confirming the presence of metastasis. Do you send off at that point, if they have not had genetics, that's like you must do this too? And then do you send, other sequencing studies then, or you do next gen sequencing automatically, or how do you work that up? Because that's a question that we often get. Yeah.
Yes. So I think we're always looking for potential actionable targets. So yes, I do reflexively do next gen sequencing. I think there are a couple of things that you may learn from that. There is an indication for checkpoint inhibition in tumors that have high tumor mutational burden. And that is an indication actually in solid tumors for pembrolizumab. So you can get that information from your next gen sequencing report. And so perhaps you'll find somebody where that's a potential opportunity in second line or later. We also can encounter PI3 kinase mutations or AKT alterations. And what we did see also at San Antonio was data from the Opportunity study looking at adding an AKT inhibitor, epatassertib, to paclitaxel. Unfortunately, even though there was really compelling, exciting randomized phase 2 data, this randomized phase 3 trial did not exactly pan out. There didn't appear to be an improvement with the addition of that AKT inhibitor to paclitaxel. And that was in an enriched population of those patients with either a PI3 kinase mutation or AKT alteration or loss of PTEN. So I think there's still a lot of work to carve out that data and take a look and try to understand it a little bit better. And there are other trials right now recruiting patients using a different AKT inhibitor, capivasertib. So I think still a little bit more to figure out in that space.
I mean, it's funny, we've traditionally thought about PI3 kinase as being related to hormone receptor. So, we got to think of it, I think, a little bit broader than what we've traditionally thought about. Yeah. Genetic wise, I think Dr. Mamounas brought up a really important point, which is so many of our patients with triple negative will have a mutation. And, one of the interesting abstracts that was in ASCO in June was looking at other pathway repair mutation genes, not just BRCA. But PALB2 in particular seemed to correlate with the response to PARP inhibitors. So I think it's going to be really important for us to, keep our eyes and ears open. So I think we're going to be looking more than just at BRCA mutations, I think. And again, it's an oral agent, it's well tolerated. So lots of other important findings, I think, with that. Well, we have to talk a little bit about neoadjuvant triple negative patients as well. And I think, first of all, what's the criteria for getting neoadjuvant treatment versus going to the OR? Do you use size criteria? Do you use grade, Key 67 in the setting of triple negativity? Or Dr. Mamounas, what do you feel is, how do you determine whether a woman has surgery first or undergoes neoadjuvant?
So our institutional practice is to offer neoadjuvant therapy for anybody with T1C and higher for triple negative breast cancer patients. And pretty much size is about the main discriminant, because obviously most of these patients have high-grade tumors. Ki-67 is invariably very high. So I think size is about the only one. Sometimes, of course, you do a biopsy and it's triple negative, but it's a lot of DCIS and very little invasive cancer with a small tumor. That is the patient that will go to surgery first. I think the question we ask, because we're not sure how much invasive tumor is, the question we ask our oncologists in the discussion is, would you do something different in terms of what chemotherapy you're going to give if, let's say, this patient had surgery and is not negative with 1 centimeter tumor? And if the answer is yes, then we can take the patient to surgery. If you do TC times 4 or 6 versus an anthracycline-based therapy. But if we can decide up front that we're going to go full blast and give anthracycline followed by taxane with or without, carbo, then we'll do neoadjuvant therapy. And the main reason, obviously, that has been discussed a lot as of late is that following the neoadjuvant approach, you may potentially improve outcomes of the patient because you have the ability to detect if they have residual disease and add additional adjuvant therapy, or perhaps even enroll them in ongoing trials of immunotherapy and others. So that is the main reason that we now favor that approach for triple negatives as well as HER2 positive patients.
So then that begs the question of, should we be doing PDL1 analysis before neoadjuvant? Should we always make that? Should we not make that part of our pathway only when they're metastatic? But because there's a lot of good neoadjuvant Pembro data now. suggesting a doubling. I think it's I-SPY that has a doubling in the response rate. So what do you think about adding PDL1 before you do neoadjuvant?
Well, I'll let Tiffany probably answer that more, but I mean, of course, we have data with the I-SPY, we have data with atezolizumab, we have data with pembrolizumab. We don't have an approval yet with pembrolizumab, so that's probably what's holding us back right now. But clearly, we have seen that pathological complete response significantly improves, is improved with the addition of immunotherapy, and also potentially having a biomarker of that response, which is essentially PDL1 expression, and the magnitude of PDL1 expression, even for both groups that don't get immunotherapy and a group that gets immunotherapy. So clearly, I think we're going to get there. Whether we're going to get there in the next few months or we'll get an approval, I think eventually we're probably going to start testing for PDL1 for triple negative patients for sure. Tiffany can chime in.
Other thoughts,
Yeah.
Tiffany?
Yeah, I think what's a bit surprising perhaps is that in the early stage setting, in contrast to metastatic setting, while yes, you see PDL1 seems to be almost prognostic, right? Folks do better, have better response if you're PDL1 positive, even if you're just getting chemo. You still seem to have an advantage to a checkpoint inhibitor in early stage disease, even if you're not PDL or your tumor's not PDL1 positive. So it'll be curious to see what kind of indication and label we'll have. We need to remember that the patients on those neoadjuvant trials had larger tumors or node positive disease. So we'll still have some questions around what to do with the woman who has a 1.8 centimeter node negative, triple negative cancer, who, you know, in your practice may end up having gone for neoadjuvant therapy, but wouldn't meet the indication for adding a checkpoint inhibitor. And we still don't entirely have the mature event-free survival data and ultimately overall survival data, which is what we're really aiming for, more so than perhaps CR.
I think that it's an exciting area. I think this time next year we may have a little bit more information. Yeah, hopefully. Yeah, absolutely. Any questions? My chat room is open, I do believe, and I don't see any questions. Dalen, if I'm incorrect, could you give me a test to make sure I haven't missed something? Because I see no questions from those that are I still see the test. Okay. Those of you who are watching, please. Oh, thank you for giving us a question. So the question is, in a BRCA positive PDL1 greater than 10, actually, I'm sorry, I lost the box. Dalen, can you flash it back? Okay. Would you go with immunotherapy first or a PARP inhibitor? So the big question, sequencing. So we're going to say this is a metastatic patient that has both BRCA positivity and PDL1 positivity. Which drug would you use first?
Yeah, great question. One we debate around and around often. So I think we have now from the Impassioned study, and we also have from Keynote, really compelling evidence to be using that checkpoint inhibitor in the first line setting. There are plenty of trials looking at combination PARP inhibition as well as checkpoint inhibition. There's a Keeling study looking at first line Gem Carbo Pembro, actually, with then a randomization to keeping that regimen as maintenance versus switching over to olaparib with Pembro. And there's a great rationale for combining checkpoint inhibition with PARP inhibition. So hopefully this will be unanswered only for a little while longer. But my inclination would be to try to get that checkpoint inhibitor in early in the first line, knowing then that I have my PARP inhibitor to come in right afterwards if need be.
And I assume if you treated neoadjuvantly, you probably would not retreat in the metastatic setting. How do you believe, you don't believe that all inhibitors are the same, I assume, or how do you feel about that?
Is that in terms of checkpoint inhibitors?
Yes.
Yeah, so I think that's a lot that we need to still figure out. So there are plenty of studies exploring in the metastatic setting whether there's benefit following progression on a checkpoint inhibitor. We don't yet have enough folks who've had this in the early stage setting, unfortunately relapse and be faced with this decision in the first line setting. So we need to see the trial data to really understand that.
We don't have science to drive us yet. We have theories, but no science yet.
Right. Right.
So one of the things that in the neoadjuvant world is trying to assess early response. And there was a very nice poster from the UCSF group looking at serial collected plasma and circulating tumor DNA. And if there was a early decrease in the circulating tumor DNA, this was associated with improved responses. And again, this is in the neoadjuvant setting. And so I guess I would question, do we think this is ready for primetime Monday morning? Will we need more information? It's obviously very interesting, but do we think this is a way that we'll be monitoring our patients neoadjuvantly to make sure they're seeing an early response? Any thoughts on that? Clearly, it's an area of investigation. Terry, your thoughts?
Yeah, no, I mean, I think that's, I would say the short answer is probably we're not ready for Monday morning, but it's a very promising approach in a variety of clinical settings, including the neoadjuvant therapy. Obviously, you know, we do give neoadjuvant therapy to monitor response. Now the question becomes, do you get the same information by monitoring the size of the tumor as you monitor the decrease in circulating tumor cells? Are they independent or do they add value? I mean, people have tried to do that with PET CTs and other methods where we see the early drop in labeling, you know, in activity, in uptake, but circulating tumor cells or circulating DNA, I think, has the promise to help not only the neoadjuvant setting, but also the adjuvant setting, to make that sort of like a neoadjuvant setting where you can monitor the circulating tumor cells that can tell the patient if they're potentially responding or getting benefit from the treatment that you give. There are a lot of questions that need to be asked and answered. For example, is that independent of pathological complete response? Does it add to the prognostic significance of PCR or even residual disease? And I think as we get more and more information, because we have several trials that collect now blood and will answer these questions, we can refine the paradigm of how we treat patients. I give you sort of a hypothetical, you know, patients, for example, that have locally advanced breast cancer, present with multiple nodes or large tumors, even if they get a PCR, they have higher risk of recurrence than, let's say, a T2 and 0 patient. So is it because they're circulating tumor cells that we're not being able to kill? And so the model can be refined, or then the clinical question is, would these patients even benefit from additional, let's say, capecitabine as triple negative breast cancer or TDM1 for HER2 positives? So these are important questions, and circulating DNA can give us some of the answers to move forward. So it's very promising, I think.
And in oligometastatic disease too. You know, I think that, you know, that's such a frustrating area that potentially it could help us. Let me ask Erica and Maimah, from a patient perspective, doing serial biopsies versus serial blood draws, do you feel that there's an advantage or a disadvantage? You know, do you feel that patients would feel that one's better or easier than another? I mean, what are your thoughts?
Maimah, you're the best to answer this.
You go first. No, you go.
No, go ahead.
Well, I think it's scary to get multiple biopsies. I think it's frightening. So I think the blood draws are more important, or, you know, that's easier on patients. But to the conversation here, I think what empowered me as a patient more is being able to understand data. And as we're talking about all these, you know, this information, again, I go back to making it palatable to patients and making them part of the conversation as to what are we doing? Why are we doing it? What are the advances? What do they mean? What do they mean for me? What do I want? And how is that going to make my life better? So what I love is seeing more patients at the table like this, where they're being asked questions, but the people who aren't even asked because they're in rural communities, they're not, you know, trained speakers. They haven't had 14 years in this space. And so for me, I love this kind of conversation, but I love to see more patients that are facing disparities at the table, being asked these questions and being a part of the curation of the solution. So in my opinion, biopsies, too many of them, it makes me nervous. But I would like to hear from people who are watching, who are patients of color, who may be able to give insights because they're in treatment right now. So if they're watching, if you're on, please provide your feedback.
And I think it's not just of color, by the way. I think all women, it is very.
You're right, all women, yes.
Anxiety provoking, biopsies are frightening. It's very overwhelming. We're always fearful of the unknown. I think that's very overwhelming for any and all of us. And I do think that, you know, serial monitoring in the metastatic setting is something that we talk about. And sometimes I think it's more anxiety provoking, you know, we have to be very cautious about that. And that a lot of that's going to be individual.
But I think even if you're not metastatic though, I mean, being a TNBC survivor of 14 years, we had Trodelvy that was what, in June of this year, that we had one treatment for TNBC patients who are metastatic. And so I have to admit, I have had fear around that, you know, am I going to have a recurrence? You know, when I had a cough, lingering cough, back pain, bone pain. But I think that the needs are not just scientific, it's about the psychosocial needs of the patient as well. And what that means for them having this disease long-term, even if you are a survivor. So those are also important patient needs that have to be, you know, addressed. So especially being people who are, you know, long-term survivors, you have that fear for a long time because you are living and thriving. But again, every little thing is a concern for me and for many of those who are patients who are long-term, you know, with this disease. So I just think that we can't forget that part of it, the emotional, mental needs that patients live with every day. And some who have, you know, who are more financially, you know, stronger can get therapy and have more community for support. And those who are not, don't have those kinds of accesses like, you know, therapy and mental health and so forth.
What do you think about a support system where someone like yourself, who's a 15-year survivor, helps, say, a newly diagnosed, you know, kind of a matchup, you know, that is part of the team, so to speak? I'm not saying you personally would have to do it, but if you were
every day. This is my phone has
only one of you, and we need 100,000 of you. So
well, we're doing that at Tigerlily. We're actually training advocates of all colors. We train 180 this year across the country to be patient peer navigators. Some metastatic, some not, but they're different disease states and types. And they're being trained to partner with patients to guide them, to talk with them, to help build that trust. Because if you don't understand treatments, trials, all these words you're talking about right now, this whole 10 minutes of conversation to a patient, it's like WTF, I don't understand any of that. And so our patients partner with you know, women who are, you know, just coming into the boat to help them understand those tough to understand words, to say, here's what I did, here's what you can do next, here are the new advances. And so it's important to, you know, have those partnerships with your hospital center or just people that already have these large establishments to help build patient trust by partnering with patient groups that are smaller on the ground or patient advocates with larger comprehensive cancer centers.
Yeah, I think that's so very, very important what you just said. And, you know, I think your Tigerlily program is very exciting. I can tell you we need it in Cincinnati, so we'll probly be bugging you after.
Let's talk. I love being bugged. I'm very buggable.
I'm going to get my nurse navigator, you know, on your fast dial here.
Yes.
I've had a couple questions about the role of platinum salts in triple negative patients. And it's actually kind of boiled down, when do we use it? Should it always be incorporated in the adjuvant setting? Should we always use it in the neoadjuvant? When do we use platinum for our triple negative patients?
Gosh, so, you know, I think that in the early stage setting, this is going to be an even more heightened debate around the keynote data, because in that neoadjuvant Pembro trial, the backbone chemotherapy was both anthracycline, Cytoxan, taxane, and carbo. And you see an incremental advantage to adding Pembro to that really complex chemotherapy regimen, including a platinum. I would say that we really have mixed evidence about whether incorporating a platinum in early stage disease has an impact on long-term survival. And we know that it adds toxicity. We know that it makes it more challenging to deliver your full taxane complement, where taxanes are associated with the survival advantage. So I think that it'll be interesting to see with the checkpoint inhibitor indication, if that comes, whether that's going to drive people to incorporate more platinum in their neoadjuvant regimens, which not everybody needs. I think in the metastatic setting, we know that platinums are active. The TNT study showed us that for a woman who is not a germline BRCA mutation carrier, taxane and platinum were comparable in their benefit. But there did appear to be an advantage to the platinum if you carry a germline BRCA mutation. So I do think that you see more platinum usage in the metastatic setting. It's an active drug, and there's still a lot of debate around its early stage role. I will say I tend to start my neoadjuvant regimens with AC and get a sense of how folks are responding. Am I getting good tumor shrinkage? And do I really need to incorporate the platinum to the taxane? Try to get a little bit of in vivo sensitivity before making that decision.
Mhm, mhm.
Terry, I don't know what your thoughts are.
I agree. I think that's what we do too, although, you know, we start with the AC. Obviously for patients, for example, that present with the T3N1 or N2 disease, I mean, they will get platinum most of the time. Otherwise, we'll start with the AC and then adjust if there's not a good response midway, we'll add carbo. If there's a great response, we may continue with, the taxane. I mean, the trials, of course, the immunotherapy trials started with the taxol carbo followed by AC, so it's a little different. I'm not sure, what's the best way to do it. I mean, there's data, I think, that point out to doing it with the taxane first in terms of resistance. But I think for patients with high risk lesions, I think carbo is usually we use, at least in our institution. For other patients, we'll go simply with the AC taxol unless there is response. There is no response or minimal response, in which case we add it.
There's also a question about timing of immunotherapy. If you don't get your PDL1 back, you have to send it off, which could take 2 weeks. Do you start your treatment and then add it on cycle 2, or what's your thought on that? Tiffany?
Yeah, I think that's a very practical approach. Often these women who are newly diagnosed first-line setting really don't have the luxury of waiting many weeks to get started on therapy. So if they otherwise are not a candidate for a clinical trial and you've had this discussion with them, often we're beginning the taxane backbone, waiting for that information on PDL1 to then incorporate the checkpoint inhibitor. Yeah.
So I think, and that's often what we do. I don't think there's any problem with that. Yeah. So usually that works well. It looks like we have about 10 minutes left. I'm going to give everybody a chance. Well, first of all, if we have more questions coming in, but I want to give everybody a chance to tell what they think has been the most practice changing thing in, it doesn't have to be just San Antonio, but anything that's happened in breast cancer in 2020. Through the pandemic, we've had new drugs, we've had new anti-HER treatment, we've had new triple negative drugs approved. Clearly immunotherapy has been very exciting. Is there one thing, and I'm actually would like to start with Erica, who volunteered. That's even better. Erica, what are your thoughts in our remaining moments? What's been the best part from your perspective at Komen?
I think the best part is the opportunity for the breast cancer community to come together and really provide a leadership role as a part of the recovery from COVID. What worries me the most and what scares me and keeps me up at night is knowing that the screening rates have gone down and what the repercussions for clinics being closed, rural hospitals closing their doors because they just can't afford the bills anymore. And then patients staying home because they're scared to death because of the virus. And what we're facing, Dr. Ned Sharpless, the NCI director, issued a warning that if women don't start getting screened again, he's conservatively projecting upwards of 10,000 more breast and colorectal cancer deaths over the next decade. And that's pretty darn scary. So the best thing I think that's come out of COVID is for us to kind of put our stuff aside and just hopefully come together as a community and get to collaborate on discussions like this, where we're proactively and aggressively thinking of strategies to move the needle and hopefully prevent all of those deaths that we don't want to see in the future.
Very, very important. Ms. Karmo, what are your thoughts?
So I get one thing or more than one thing?
1.5, how's that?
Okay, I
I'll let
think
that too, for sure. You may
I'll
have,
cheat. I always will. So I think the important thing, one thing that's happened is seeing how we've innovated with in terms of getting patients access despite COVID, getting patients, PPE to get to treatments. I think screening has gone down. It has gone down. I don't think I know, but we've done a lot of things faster than we would have year before or 6 months before COVID. The focus on health disparities has really been important. I mean, we've seen some things happen that were horrible, but it made us see what we're facing as human beings of all colors and how we have to become one to connect and to hear and listen and be vulnerable and look at our biases and come together to heal the world. And also lastly, sorry, one last thing, having patients start to lead with providers. San Antonio Breast, I opened it up last week, Tuesday, and they never before had a patient open it up and have a talk about health disparities and barriers and vulnerability and pain and things, Erica. And so I think for us to work together and to change how we've been working, we have to go back to, again, science, soul, what happened in the past, and how to heal together and build a better future. So those are things that I've seen that really have changed the past year.
very important. What do you think, Tiffany?
Oh my gosh, I think Erica and Maimah said it so beautifully. And I really think it's not, what rises to the top for me is not about the great new drugs that have been approved, which is also wonderful, and the science has been great, but it's really been this reflection on what is truly important and what we can accomplish when we really work together.
Yeah.
We've seen some of the darkest times this year, but maybe it's a choice. It's a choice to focus on the silver linings in establishing what our priorities are and being proud of what we can really accomplish if we're dedicated to it. So I think maybe I choose to look at the silver linings. I think we can do a better job in making clinical trials easier for patients to participate in, improving access in real ways, eliminating barriers. Look at how quickly we stood up telemedicine. I think we saw a 3,000% increase from February to now. We can do these things if we really are committed to it. So I think that's been some of the positives.
Absolutely. Thoughts,
Yeah, I will echo that, I think, because I think obviously went through the COVID and you see sort of how we have adjusted even from the beginning of the pandemic to now, where patients now feel much more comfortable coming to the clinic, being seen with protective equipment and all that. But initially, obviously, there was a big fear. But then let's now take the positives from this and continue those over time. Telemedicine, be able to do even clinical trials remotely. Why does everybody have to come in for a consent and you cannot do it over the telemedicine?
Yeah.
I mean, we do documents, you can sell your house or your everything, and you never can go anywhere else but sitting at your, what I mean? So I think let's take all that stuff and make the best out of it. And I think at the end of the day, we'll come out stronger because we're able to adjust. Which sometimes what they say, what doesn't kill you, make you stronger. I think that's what's going to happen here. And I think we need to take advantage. Yeah. I mean, even these meetings, we can do all these meetings without having to travel a lot. Let's keep some of that. Let's not all go traveling everywhere again, like we've done in the past 20 years. I mean, there is ways. So maybe we can adopt a hybrid model. Maybe we can adopt, communication. To be honest with you, as much as I miss San Antonio and all the, the camaraderie there and seeing everybody, it was nice to sit in my home and my computer and actually undivided attention, look at the meeting. Usually we're running into so many other meetings. So there is a silver lining here. And I think we need to finish the vaccine story. I mean, it's unbelievable that we can get a vaccine in 8 months. It's just unprecedented. Why can't we do this with cancer? Why it takes 3 or 4 years to open a clinical trial? I mean, it's
actually, I had a patient just today that said, if we can get like 4 or 5 vaccines for COVID in a year and a half, why can we not get a vaccine for my breast cancer? Yes. Of course, there's been people looking into this for decades, but again, part of it is dollars and part of it is knowledge and everything else. So, Yeah, I think it's clearly been an exciting year. And I've been impressed with how everybody's pulled together. I think that's the best part. Yeah, I think that's really been a good thing. Well, I want to thank our panel again for all their expertise in making us realize the importance of the patient side of the science. And I appreciate everyone's interest. I also want to make sure that sponsors, Pfizer, Natera, and then Gilead. And I'm going to turn this back. I think we have, by my clock, about a minute and a half to go. So I'm going to conclude things. I don't think that we have any more questions in the chat, but Dalen, anything else from your end that we should be doing? Or if not, we'll close a couple minutes or a minute early, unless anyone has any final comments. So thank all of you for your participation, and particularly those in the audience. Thanks.
Oh, Elyse, there's one more question in the chat.
Oh, I didn't
You-
see it. I'm sorry.
And that's okay.
Can we capitalize prognostic and predictive value of TILs? Is that the one you're talking about?
The one I just sent, it says, if approval comes through, are you going to incorporate
Contested trial based oral, yeah, in your practice and in which patients, yeah. So if approval, will we incorporate the contested trial into our practice, which is the oral docetaxel? And if so, in which patients?
So Contessa was in hormone receptor positive, HER2 negative patients in the first line setting. Yeah, so doublet chemotherapy giving a small improvement in PFS. I'm not entirely sure. We know we see a small incremental advantage, but it's balanced by increased toxicity.
We may talk about that in the next section, who knows?
Yeah, stay tuned.
Well, thank all of you again, and good luck with the blizzard. Bye-bye, good night.
Bye.